بسم الله الرحمن الرحيم. هنتكلم عن البون and joint infections. البون infections أو osteomyelitis can be classified into three main categories: acute, subacute, or chronic. Joint infections are called septic arthritis. Regarding acute osteomyelitis or septic arthritis, can be defined as acute suppurative inflammation of bones or joints. Regarding subacute osteomyelitis, these are infections characterized by insidious onset. They are caused by low virulence organisms affecting more immune patients. The most common example for subacute osteomyelitis are Brod's abscesses. Regarding chronic osteomyelitis, these are infections characterized by persistence of low-grade inflammation and are characterized by formation of sequestrum, which is dead bone, and formation of sinus tracts pouring pus to the exterior. Regarding the etiology and risk factors, the main origins through which infections may come to bones or joints are the following. Infection may come through bloodstream via nutrient arteries to the bone. Infection may spread from nearby tissues, or infections may invade bones directly secondary to trauma or surgery. Regarding the most common organisms affecting bones and joints, in newborns and children, Staph aureus and Streptococci are the most common organisms. In adolescents, Staph aureus, Streptococci, Enterobacteriaceae, Haemophilus influenza are the most common organisms. In adults, Staphylococci, Streptococci are the most common organisms. Other organisms include Salmonella and Pseudomonas aeruginosa. Regarding the predisposing factors, these may include chronic debilitating diseases like diabetes mellitus, chronic renal failure, rheumatoid arthritis, or anemia, or may include immunocompromised states like patients taking steroids or immunosuppressive drugs. Also may include prematurity and old age, and finally may include trauma or surgery. Regarding classification of bone and joint infections, acute osteomyelitis is characterized by time onset from 2 to 4 days and up to 2 weeks. Subacute osteomyelitis is characterized by time onset from 2 to 3 weeks up to 3 months. Chronic osteomyelitis is characterized by time onset more than 3 months. And this picture shows the pathogenesis of acute osteomyelitis of the proximal tibial metaphysis, and its spread horizontally, making subperiosteal abscess, or through the joint capsule, leading to formation of septic arthritis. Regarding the clinical presentation, we will divide it into 4 main points. The first point is type of patient and features of the cause, like diabetes mellitus. The second is symptoms. The patient may complain of general symptoms like fever, arthralgia, headache, malaise, or local symptoms including pain, swelling, limitation of movement, or limping. The third may include signs. General signs include fever, and local signs we will divide it into 3 main items. The first item is look. Look at the skin to detect any abnormality, like swelling, redness, sinuses, or scars. Look at the gait pattern. You will find that the patient is walking with antalgic gait. Look at limb length discrepancy and rotational profile of the lower limbs. You will detect abnormalities in chronic cases. Look at any visible deformity. You will detect it in chronic cases also. The second item is feel. Feel for palpable swelling. Palpate for tenderness or hotness. Examine for neurovascular status. The third and last item is move the nearby joints. You will find a limitation of the range of motion, either passively or actively. Regarding the investigations, we will ask for complete blood count, erythrocytic sedimentation rate, and quantitative CRP. Quantitative CRP is the most sensitive monitoring tool for monitoring the response for treatment. It is elevated in 98% of patients with acute osteomyelitis or septic arthritis. And these are Kocher's criteria for diagnosis of acute septic arthritis. They include non-weight bearing, elevated temperature beyond 38.5 degrees, elevated ESR beyond 40 mm per hour, and elevated total leukocytic count beyond 2000. If one criterion is present, the probability of septic arthritis is present in this patient as 9.5%. If two criteria are present, the probability of septic arthritis jumps up to 35%. If three criteria are present, the probability jumps up to 73%. If four criteria are present, the probability jumps up to 93%. However, as we said before, quantitative CRP is the most important tool for diagnosis and monitoring the response of treatment to antibiotics in acute septic arthritis. Regarding the radiological investigations, we will ask for conventional X-rays. In acute osteomyelitis, we may find metaphyseal mottling, periosteal reaction. In Brod's abscess, solitary lytic lesion may be found surrounded by sclerotic rims. In chronic osteomyelitis, we may find lytic lesions followed by sclerotic lesion formation, and we will find sequestrated bone. We can ask for ultrasonography in cases suspected with acute septic arthritis, and we will find joint effusion. And finally, we will ask for MRI for early diagnosis of acute osteomyelitis, detection of subperiosteal abscess, and differential diagnosis from neoplastic lesions. The left picture shows mottling of the metaphysis of the proximal tibia and periosteal reaction. The right picture shows single lytic lesion in the proximal tibial metaphysis surrounded by sclerotic rim. So, the left picture is an X-ray examination of a case with acute osteomyelitis of the proximal and midshaft tibia, and the right picture shows Brod's abscess. This X-ray shows deformation of the tibial shaft, thickening of bones, multiple lytic lesions surrounded by sclerotic lesions, and sequestrum formation. So this X-ray examination is indicative of a case of chronic osteomyelitis. This X-ray pelvis of a skeletally immature patient shows widening of the joint space on the right side more than the left side, and periosteal reaction at the proximal femoral metaphysis. This is indicative of acute septic arthritis of the right hip in a newborn. This is MRI examination of the knee showing increased signal density in the proximal tibial metaphysis, indicative of acute osteomyelitis. This is MRI examination of the pelvis showing both hips, showing increased signal density changes in the capital femoral epiphysis on the right side, and increased space around the right proximal femur, and increased dimensions of the right hip capsule, and increased signal density indicative of joint effusion. This MRI examination is indicative of acute septic arthritis of the right hip. This is ultrasonographic examination of the hip showing right and left hips, showing joint effusion on the left side with elevation of the joint capsule. Regarding treatment, we will divide treatment into two main lines of treatment. The non-operative treatment is indicated in acute osteomyelitis as a first line of treatment in early presenting cases, in Brod's abscess cases as a first-line treatment, and in some cases of chronic osteomyelitis, where massive debridement of the bone is impossible or where the patient is surgically unfit. We will continue on antibiotics for 4 to 6 weeks with optimization of the underlying causes. Regarding the second line of treatment, which is the operative treatment, it is indicated as a first line of treatment in septic arthritis, where drainage of pus must be considered as early as possible for prevention of cartilage damage or physeal arrest. It is indicated in cases of chronic osteomyelitis, where debridement and reconstruction of bone defects with stabilization of the infected bones must be done. It is indicated in acute osteomyelitis with drainage and drilling of the infected bones, where the cases show failure of conservative treatment, or the MRI show subperiosteal abscess formation, or there is acute exacerbation on top of chronic infection. Lastly, it is indicated in Brod's abscess with drainage and debridement of the lesion, where the cases show failure of conservative treatment, or the MRI show subperiosteal abscess formation, or there is chronic infection.
Bismillah ar-Rahman ar-Rahim. The topic of this lecture will be about rickets. The intended learning outcomes is to know the definition of rickets and to understand the pathophysiology of different types of rickets, and to know the clinical presentation, the laboratory studies needed to reach the diagnosis, and the basics of treatment of different types of rickets, and lastly, to know the rickets-like condition and how to differentiate between them and rickets. The definition, rickets is a metabolic bone disease that develops as a result of inadequate mineralization of the growing bones due to disruption of calcium and or phosphate metabolism. So it is a disease of the immature skeleton. A similar condition of inadequate mineralization of the mature skeleton is called osteomalacia. It is not called rickets. Pathophysiology of this condition begins with the disruption of calcium and phosphate metabolism. Calcium and phosphate are important in the formation of the hydroxyapatite, which is the inorganic component of bone. The deficiency of calcium and phosphate result in poor mineralization of osteoid matrix of the growing bone. The mineralization of bone occur in the hypertrophic zone of the physis, mainly in the zone of provisional calcification. So this results in widening of the zone of provisional calcification with cortical thinning and bowing deformities. Clinical picture of rickets, it is a generalized condition affecting the whole skeleton. So there will be a brittle, weak bones with physeal cupping and whitening, as we can see in the photograph of this swollen wrist. Also, there will be deformities in the form of genovarum or vulgum, ligamentous laxity, flattening of the skull. In the chest, there will be rachitic rosary, which are enlargement of the costal cartilages of the rib cage. Also, there will be Harrison sulcus, which is indentation at the site of diaphragm attachment. There also will be a growth retardation and generalized bony pains and poor immunity, which are mainly due to vitamin D deficiency. Rickets have a unique radiographic picture consisting of increasing in the width of the physis with metaphyseal cupping and swelling, with bowing deformities of the long bone, and decreased bone density and rarefaction and moth-eaten appearance of the bone, as we can see in these X-rays. Now we will discuss the classification and different types of rickets. The most common type of rickets is the vitamin D deficiency rickets, also called nutritional rickets. It's mainly due to deficiency of vitamin D and calcium. Genetic causes of rickets include vitamin D dependent rickets, which have two types, type 1 and type 2, as we will discuss later on, and vitamin D resistant rickets, which is also called the familial hypophosphatemic rickets. It is very important to know and understand vitamin D metabolism. Sources of vitamin D in the body include either absorption from the GIT or its biosynthesis in the body. Its biosynthesis begins in the skin under the effect of exposure to sun, mainly ultraviolet rays and UVP, which stimulate the conversion of 7-dehydrocholesterol to cholecalciferol. Cholecalciferol is the inactive form of vitamin D. It is carried in the bloodstream, bound to vitamin D binding protein until it reaches the liver, where it undergoes 25 hydroxylation to form 25 hydroxycholecalciferol. This is the main storage form of vitamin D in the body, and it is the main laboratory study used to diagnose vitamin D deficiency. The final activation of vitamin D occurs in the kidney under the effect of 1-alpha hydroxylase enzyme, resulting in the formation of 1,25-dihydroxycholecalciferol, which is the active form of vitamin D. It acts on the intestine to increase the intestinal absorption of calcium and phosphate, also acts on the bone to stimulate the terminal differentiation of osteoclast. There is a feedback mechanism to control the level of active vitamin D in the blood, and this depends on the plasma calcium concentration. When there is hypocalcemia, this will stimulate the parathyroid gland to release the parathyroid hormone, which will stimulate the 1-alpha hydroxylase enzyme, increasing the level of active vitamin D in the blood. Parathyroid hormone will also act on the kidney to increase the intestinal, reabsorption of calcium and the excretion of phosphate. It will also act on the bone to increase the bone resorption and the release of calcium and phosphate from the bone to the bloodstream. Now we will discuss the different types of rickets, starting with vitamin D deficiency rickets or nutritional rickets. It is the most common type of rickets, occurring in 87% of cases. It is mainly due to lack of sunlight exposure with inadequate vitamin D supplementation. It is common in premature infants, breastfed infants, as breast milk is deficient in vitamin D, and also in patients with malabsorption syndrome. Vitamin D deficiency will result in decreased intestinal absorption of calcium, and this hypocalcemia will stimulate the release of parathyroid hormone, so it is parathyroid hormone dependent. The treatment is by supplementation of inactive vitamin D form and calcium. Active form of vitamin D should not be used in the treatment of vitamin D deficient rickets. Laboratory profile of patients with nutritional rickets will consist of the following. The calcium level will be decreased or will be in the low normal range. The phosphate level will be decreased. Alkaline phosphatase will be increased. Alkaline phosphatase act to promote mineralization by increasing the availability of the inorganic phosphate. So when the phosphate level is decreased, there will be increased level of alkaline phosphatase to try to compensate for this. The parathyroid hormone will be increased, as we discussed, in response to hypocalcemia, and the 25 hydroxyvitamin D will be decreased, and also the active form of vitamin D, 125 hydroxy D, will be decreased. Another type of rickets is the vitamin D dependent rickets. It is a hereditary form with autosomal recessive inheritance. The clinical features are similar to vitamin D deficiency rickets, but are more severe. It includes type 1 and type 2. In type 1, there is defect in renal 1-alpha hydroxylase enzyme, so there will be decreased in the active form of vitamin D, 125 dihydroxycholecalciferol. Type 1 is treated by physiologic doses of the active vitamin D calcitriol. In type 2, the defect is in the intracellular receptor for 125 dihydroxyvitamin D, and it is treated by high doses of vitamin D and calcium infusion. As the intestinal absorption of calcium is dependent on the active vitamin D, which is ineffective as a result of the defect in the receptor. The laboratory profile of patients with vitamin D dependent rickets consists of the following. The calcium and phosphate level will be decreased in both type 1 and type 2. The alkaline phosphatase and the parathyroid hormone level will be increased also in both type 1 and type 2. 25 hydroxy vitamin D, the inactive vitamin D, will be increased or normal in both type 1 and type 2, but the active form of vitamin D, 125 dihydroxy vitamin D, It will be decreased in type 1 due to the defect in 1-alpha hydroxylase enzyme, but it will be increased in type 2 as the defect is in the intracellular receptor of active vitamin D. Regarding the response to calcitriol, type 1 will have good response to calcitriol, and type 2 will have no response to calcitriol as the defect is in the receptor. Another factor to differentiate between type 1 and type 2 is the presence of alopecia, which is mainly present in type 2 vitamin D dependent rickets. Vitamin D resistant rickets, also called familial hypophosphatemic rickets, is another form of hereditary types of rickets with X-linked dominant transmission. It is the result of mutation of PHEX gene, resulting in stimulating the expression of fibroblast growth factor 23, which is expressed in the bone. The increased level of this hormone, the fibroblast growth factor 23, will result in phosphaturia and hypophosphatemia, and it will also inhibit 1-alpha hydroxylase, so it will decrease the active vitamin D. The parathyroid hormone level in this type of rickets will be normal or mildly elevated, as it is inhibited by the hypophosphatemia, and at the same time it is stimulated by the hypocalcemia caused by decreased active vitamin D, resulting from inhibition of 1-alpha hydroxylase enzyme by the increased fibroblast growth factor 23. The normal level of parathyroid hormone in hypophosphatemic rickets is important in differentiating this type of rickets from the other previously discussed types of rickets where the parathyroid hormone level will be elevated. The pathophysiology of hypophosphatemic rickets, it begins with mutation in BHEX gene, resulting in increased level of fibroblast growth factor 23, as we said. This increase in the fibroblast growth factor 23 will result in decreased reabsorption and increased excretion of phosphate in the kidney. It will also inhibit the 1-alpha hydroxylase enzyme. This will result in phosphaturia and hypophosphatemia, and it will result in decreased active vitamin D level, which in turn will decrease the intestinal absorption of calcium and phosphate from the intestine, contributing to the hypophosphatemia. Both the hypophosphatemia and the decrease in the level of active vitamin D will result in rachitic manifestation of the skeleton. Laboratory profile of hypophosphatemic rickets include the calcium level will be normal or low normal as a result of the suppression of active vitamin D. The phosphate level will be decreased due to phosphaturia caused by increasing fibroblast growth factor 23. The alkaline phosphatase level will be increased as a result of hypophosphatemia. The parathyroid hormone level, as we discussed, will be normal or mildly elevated, as it is both suppressed by the hypophosphatemia and stimulated by the hypocalcemia. 25 hydroxy vitamin D, the inactive vitamin D level may be normal, but the active vitamin D, 125 dihydroxy vitamin D, will be low, as it is due to inhibition of 1-alpha hydroxylase enzyme by the fibroblast growth factor 23. Treatment of hypophosphatemic rickets. The recent research found no additional benefit with phosphate supplements, as intestinal absorption of phosphate is dependent on active vitamin D, which is suppressed. High doses of vitamin D will increase the level of calcium in the blood and in the urine, but this is together with the increased phosphaturia will may risk iatrogenic nephrocalcinosis. In 2018, FDA approved porosumab for X-linked hypophosphatemia. Porosumab is a monoclonal antibody that binds excess fibroblast growth factor 23. The management of hypophosphatemic rickets occurred by the pediatric nephrologist or endocrinologist, and the orthopedic management of these patients is limited to the surgical treatment by corrective osteotomy to realign the deformed limbs. There is a number of rickets-like conditions which should be considered in the differential diagnosis of rickets. These include hypophosphatasia, which is an autosomal recessive condition where there is a defect in the alkaline phosphatase. It has similar clinical features to rickets, but the labs will show decreased alkaline phosphatase with increased levels of calcium and phosphate. Also, metaphyseal chondrodysplasia is a type of skeletal dysplasia with autosomal dominant inheritance. They have similar clinical and radiographic features to rickets, but they have normal metabolic profile unlike different types of rickets. Our take-home message is that rickets is a metabolic bone disease of immature skeleton characterized by poor mineralization of osteoid matrix. Different types have similar clinical and radiological picture. Laboratory investigation can differentiate between different types of rickets. Inactive vitamin D is standard supplementation used in nutritional rickets. We should not use the active form of vitamin D in the treatment of nutritional rickets. And rickets-like condition should be considered in the differential diagnosis. Thank you.